In this video, we're going to take a deep dive into niacin and its effects on heart health. It used to be given as a supplement therapy to further decrease triglycerides and increase HDL, but that is no longer the case as it has lost popularity. So we are going to look at two big meta-analyses going over not only its efficacy, but also its side effects. So let's get into that. But before we go into the actual studies of niacin in terms of its effectiveness and side effects, we're first going to look at the mechanism and how it works. So this figure here shows the places where niacin comes in. It works on adipose tissue and on the liver. The left is the adipose tissue and the right is the liver. On the top left here, we see that niacin binds to the HCA2 receptor, which leads to inhibition of adenylocyclase. That leads to CAMP, less pKa, and then less free fatty acids. This less volume of free fatty acids means less PGC1 beta, which results in less VLDL and more HDL. And niacin also works on the liver by blocking DGAD2, which stands for diacylglycerol acyltransferase 2, and that directly reduces triglyceride synthesis, meaning we get less triglycerides. This results in less VLDL and more HDL. On the top right, we see niacin blocking the hepatocyte HDL catabolism receptor beta ATP synthase, which inhibits HDL reuptake, which basically just means that it increases HDL. This is why niacin is thought to have positive effects on heart disease. It can decrease triglycerides and increase HDL. That's basically, in a nutshell, what we're seeing in this mechanism here. We reduce triglycerides and increase HDL, which is kind of known as the good cholesterol, so it should have positive effects on cardiovascular disease. However, that's not always the case. Just because something improves biomarkers doesn't necessarily mean that it can improve outcomes. So in this video, we're now going to look into some studies to see if it actually has positive outcomes on cardiovascular disease, not just better biomarkers. So let's look at the first study here, which is titled Niacin in Patients with Low HDL Cholesterol Levels Receiving Intensive Statin Therapy. So this study consisted of 3,414 patients, basically split into two groups of treatment versus placebo. Treatment group took 1,500 to 2,000 milligrams of niacin extended release per day, and the placebo group did not take any niacin at all. However, this is not a true placebo group, as all patients took simvastatin 40 or 80 milligrams per day, and possibly ezetimibe as an add-on therapy to control LDL cholesterol levels. The goal of LDL cholesterol is 40 to 80 milligrams per deciliter. So that's kind of what they're looking at in terms of if niacin can improve outcomes when patients already have this level of cholesterol control. Something important here that I want to highlight is that the study states the companies that provided financial support or products had no role in the oversight or design of the study or in the analysis or interpretation of the data. The reason I want to mention this is because a lot of people think that drug companies have their hands in these studies and they kind of can control the outcome. Just because they fund the study doesn't mean that they have any control over the design or the method or the results of the study. So I want to read that to kind of reiterate that point across, because majority of studies, especially prescription medications, are funded by the drug company themselves, because no one else is really willing to put up millions and millions of dollars to see if a drug actually works, except the company that made the drug themselves. So that's just something that I wanted to throw out there before we continue. So again, patients initially received simvastatin 40 milligrams per day plus niacin, and the niacin started at 500 milligrams per day, and every week they increased it by 500 milligrams until they got to the target dose of 2,000 milligrams per day. Now the way they increased it was they started at 500 milligrams and then they increased it by 500 milligrams every week as tolerated by the patients. And the reason why I say as tolerated is because niacin has a lot of side effects that we'll go over later on in this video. But for now, just know that if the patients were doing well on 500 milligrams or 1,000 milligrams and so on, their target dose was 2,000 milligrams of niacin extended release per day. Now, the results of the study are shown in Table 2. Statistically significant increases in HDL by 25% and statistically significant decreases in triglycerides by 28.6%. Those are very, very good results that we see of increase of HDL and a decrease in triglycerides. Now, if we pull up the supplemental appendix and look at Figure 2A, we get a nice graph of HDL increases in combination therapy versus monotherapy. Figure 2B shows a decrease in LDL cholesterol with combination therapy, and Figure 2C shows a decrease in triglycerides with combination therapy. Now, this graph, which is figure 3, shows if niacin supplementation made any difference on the endpoints. Anything on the left of the vertical line means that niacin had a positive effect, and anything on the right favors the control group. If at any point the horizontal bar touches the vertical bar, that means the result is not statistically significant, and the results are probably due to chance and not because of the niacin therapy. It doesn't matter if the square lands on the left or the right. If the horizontal bar touches the vertical bar, then the results are not significant. So keep that in mind as we go over all of these studies. The study summarizes the results here, stating extended release niacin plus simvastatin as compared with simvastatin alone was associated with significant increases in HDL cholesterol levels and decreases in triglyceride levels, but there was no significant reduction in the primary composite endpoint of cardiovascular events over a mean follow-up period of 36 months. Now, the study has a lot of flaws. Patients could have been taking 40 milligrams or 80 milligrams of simvastatin, but more patients in the placebo group were taking 80 milligrams of simvastatin than in the niacin group. The percentages are 24.7% versus 17.5%. Also, more patients in the placebo group were taking ezetimibe than in the niacin group, 21.5% versus 9.5%, which is almost double the amount of people. That kind of difference in the two groups will undoubtedly make a difference in cholesterol levels and outcomes. So this is not a very good head-to-head comparison of if niacin actually improves outcomes, because the baselines are not equivalent. Some people were on 40 milligrams of simvastatin, some people were on 80 milligrams of simvastatin, and some people were on 40 or 80 simvastatin plus ezetimibe. So we can't really even tell if any of the outcomes, positive or negative, were directly because of niacin or because the patients were on a different dose of simvastatin or they had additional therapy in ezetimibe. That's the major flaw of this study. The purpose of this deep dive is also not to show if niacin is better than simvastatin or ezetimibe, because it's not. It's not even close. Statins are significantly more effective than niacin, and so is ezetimibe. And simvastatin is not even a potent statin. Lipitor or Crestor are the more potent statins, and even simvastatin itself has much better outcomes and much better efficacy than niacin. So having a head-to-head comparison is not really fair, and there's really no competition. The point is to see if niacin added onto a statin would help reduce cardiovascular events. And the results of this study show that although it decreased triglycerides and increased HDL, it did not have any positive effects on cardiovascular outcomes. So we can kind of say that niacin did not have any additional benefit to a statin when cholesterol levels of LDL were already in target range of 40 to 80 milligrams per deciliter. We don't know if it'll have a positive effect if LDL levels were much higher or if triglyceride levels were significantly higher as well. This study did not have those parameters in place. In this case of a well-controlled cholesterol level of 40 to 80 milligrams per deciliter, niacin did not improve outcomes being added on to a statin. Now, the second study is titled Niacin for Primary and Secondary Prevention of Cardiovascular Events. This study is from the Cochrane Library, which is a very high-grade, high evidence-based research review. This is one of the best, if not the best, source of trustworthy research analysis. So it's great to have a niacin study on heart disease in this library. Let's now take a look and see what the findings are. So here's a graph of what studies were and were not included. We can see that they sifted through 7,416 potential studies and only ended up with 23 studies that matched their inclusion and exclusion criteria. So although they threw out 99.7% of the studies, they still had almost 40,000 participants across 23 studies, which is a massive, massive amount of people, and you can trust these results. Something to note is that similar to the previous study, a lot of the patients were on a statin, so this is again niacin as add-on therapy to statins, and 16 out of 23 of the studies had this kind of analysis. The patients were already on a statin, and we added niacin to it. The median dose administered was 2 grams per day of niacin, which is equivalent to 2,000 milligrams of niacin. So let's look at the first comparison of niacin for overall mortality. Again, anything on the right of the vertical line favors control, anything on the left favors niacin. Something we want to also pay attention to is the weight column. Although this overall mortality outcome is pooling together 12 studies, we can see that these last two are the ones holding most of the weight, about 90%. We can see that the CDP study favors niacin a bit, and the Thrive study favors control a bit, although neither one is statistically significant. Overall, niacin did not improve overall mortality rates as seen here. Next, we'll look at fatal myocardial infarction, which is a heart attack that resulted in a death. Again, we see no benefit with niacin supplementation. Something I want to remind you of is the p-value. So in order for something to be statistically significant, normally you'd see a p-value less than 0.05. Here, the p-value is nowhere near it at 0.92. And the diamond is pretty dead center. So we can see that some studies showed an improvement in fatal heart attacks with niacin and others did not. But again, it looks like it's coming down to the CDP trial and the Thrive trial as those hold the most weight. Same issue with cardiovascular mortality. No benefit overall, and the main driving force of that outcome is the conflicting results of CDP and Thrive. I'm going to kind of zoom through the rest of them because the outcomes are all the same. No benefit for cardiovascular mortality, non-fatal myocardial infarction, fatal or non-fatal stroke, and revascularization procedures. So on this page, we see a summary of all the findings from this massive study. Overall mortality found no benefit with niacin with high quality of evidence. Same with cardiovascular and non-cardiovascular mortality, fatal or non-fatal myocardial infarction, and fatal and non-fatal stroke. Now here's another study I want to include here that does a nice job summarizing the studies in a written format so we get a nice big picture of what's actually going on. Studies titled Niacin in the Treatment of Hyperlipidemia in Light of New Clinical Trials, Has Niacin Lost Its Place? Now they also go over study limitations on this chart, mainly the two big studies of AIM-HIGH and HPS2 Thrive. The biggest flaw of the AIM-HIGH study is what I mentioned earlier in the disproportionate separation of the statin therapy between the groups. More patients were on higher doses of statin and ezetimibe than in the niacin group. In the Thrive study, the LDL and other lipid values were already in the target range, and there really wasn't any need to optimize the levels anymore. They were already at a good enough place to prevent cardiovascular events, so the addition of niacin was probably not going to make a difference anyway. It's kind of what I mentioned earlier by saying that the cholesterol levels of the LDL are already well controlled at 40 to 80 milligrams per deciliter, so although niacin decreased triglycerides and increased HDL, we don't actually see any practical or clinical benefit from the added-on supplementation of niacin. The study claims here at the end that we believe that it will be appropriate to selectively evaluate the functioning of extended-release niacin alone in the subgroup of patients suffering from low HDL cholesterol and high triglycerides. These patients can serve as a target group, in which case adding extended-release niacin to statin treatment could be of benefit in lowering residual cardiovascular risk. So I tend to agree that if patients have high triglycerides and low HDL, adding on niacin in addition to statin therapy could provide better lipid biomarkers and possibly have better cardiovascular outcomes. The problem is that statins already do that. So unless you've maxed out the statin, maxed out ezetimibe, maxed out Repatha, which is another cholesterol lowering medication, there really is no need to add on niacin. Niacin is not as effective as these other prescription medications. A high-dose statin can reduce total cholesterol, triglycerides, and LDL by over 50%. It can also raise HDL levels. So unless you can't tolerate a statin and ezetimibe and Repatha, then there really is no need to be adding niacin to any patient group. Only those patients that can't take those medications should be placed on a niacin as a third or fourth option, never as first-line therapy. And that's not only because of its low effectiveness, but also because of side effects, which we'll get into now. Flushing is a big side effect that most people know about when it comes to niacin, and it's no different in this study. Flushing is basically when your face feels very, very hot and your body overall just feels hot as well. It also results in redness in the face, but luckily discontinuation of niacin discontinues that feeling as well. Not more redness or feeling hot right when you stop niacin therapy. In the Cochrane study, we clearly see that flushing occurred because of supplementation with niacin with a p-value less than 0.001. Same thing with itching, same thing with rashes. All the studies found that rash, itching, and flushing was caused from niacin. Only one study claimed that the rash was not due to niacin therapy. All the other ones said that those three side effects were all from niacin, and they had pretty high occurrence rates. So not only was niacin the true cause of the side effect, it happened very, very often. Overall, niacin clearly causes flushing, itching, and rashes. Next one we see that people complained about a lot while on niacin is gastrointestinal symptoms. This includes nausea, upset stomach, diarrhea, stuff like that. Anything to do with the stomach. All the studies except one showed these symptoms. Now, one that I want to go over in a bit more detail is new onset diabetes. All these other side effects, flushing, itching, rash, completely stop right when niacin supplementation stops, and they're not life-threatening or lifelong, side effects. The next day you stop niacin, these side effects will stop as well. Also, you can clearly tell flushing, itching, and rash because they have physical symptoms. You can see the redness on someone's cheeks or the rash or they're itching themselves or whatever is going on. New onset diabetes is obviously not something you can see. You can't see that your blood sugar levels have increased. So unless proper blood testing is happening, people can have no idea that their blood sugar levels have increased, and that could be life-threatening and lifelong. So the diabetes side effect of niacin is pretty dangerous. Now, statins also may increase diabetes and cause new onset diabetes as well. However, statins are way more effective than niacin, so a lot of times the benefit outweighs the risk. Either way, if a patient is on niacin, proper and frequent blood testing is warranted. Now, this Thrive study had almost 26,000 adults in it who received 2 grams of niacin extended release with 40 milligrams of laropiprant versus placebo. Laropiprant is a medication that was given with niacin to reduce flushing. It didn't actually have any cholesterol lowering effect. Its main purpose was to lower that flushing side effect. So if we look at table 2 here from this study, we see that there was a 32% increase in new onset diabetes and a 55% increase in disturbed diabetes control. This is a pretty big increase happening from niacin. Getting diabetes while trying to prevent cardiovascular disease, it's kind of counterintuitive, especially if that supplement does not show any positive outcomes on cardiovascular disease. Niacin, as we saw from the previous studies, did not show any benefit in terms of reducing heart attack or stroke risk, but it does reduce triglycerides and increase HDL. But also remember that I just said that statins can also increase new onset diabetes. So if we take these two medications of niacin and a statin together, then we're going to further increase our risk of getting new onset diabetes a lot more than if we just took one of them alone. And since statins are way more effective than niacin in preventing cardiovascular disease, it's a no-brainer to stick to statins instead of niacin if tolerated. If statins, ezetimibe, and Repatha are not tolerated or patients can't be on it, then niacin is the last choice, and we kind of have to monitor the blood sugar and those flushing side effects on top of it. So niacin doses, even at 2 grams or 2,000 milligrams, which is 12,500% more than the daily recommended intake of niacin, does not show any cardiovascular benefit from these studies. Now again, these were just add-ons to statins, so it's possible that the cholesterol levels were already well controlled and additional supplementation with niacin doesn't have any further benefit, but maybe niacin by itself could have some benefit. But again, the side effect profile and the low effectiveness compared to a statin makes this medication or supplement not, first line or any of the first choices. It's probably one of the more last line options that we have in reducing or treating cholesterol levels. So based on the current research, I would agree that niacin is a last resort in controlling cholesterol levels. Now, if you want to look at a supplement that can control cholesterol levels, that's not a statin as a medication, then look at my video on red yeast rice that I've linked over here, and I'll see you guys next time.